Now we're thinking about the longer term complications of diabetes. Now suppose if you're talking about long-term complications, it makes sense to think about short-term complications first. And the short-term complications of type 1 diabetes at any rate is that the person who is not treated will become ketoacidotic and die from the condition. And this was the case before Banting and Best discovered insulin back in, I think they discovered it in about 1922, but of course it wasn't readily available for some time after that. And of course in parts of the world where insulin is not available, then people will still die from this acute short-term complication. But given that diabetes has been treated, and this applies equally to type 1 and type 2 diabetes, then thankfully these days patients can be maintained for many decades as diabetics receiving active treatment. But they are at increased risk of long-term complications of the disease. And some of these complications are directly related to the quality of glycemic control that you as the professional working together with your patient are able to maintain. If you can maintain good glycemic control, some of the complications of long-term complications of diabetes are less likely to occur. But let's think about what these long-term complications actually are. Now, the first one I want to talk about is macrovascular disease of the large arteries. Because in diabetes there is a predisposition to the development of atherosclerosis, where atheroma collects in the walls of the arteries and progressively occludes the lumen. And if a plaque becomes destabilized and the roof of the plaque ruptures, then that means that the blood platelets come into contact with the lipid-rich core of the plaque, and this will trigger off platelet aggregation and subsequent thrombosis formation. Initially white thrombus as the platelets aggregate, but then later on it can trigger off the coagulation cascade proper, resulting in the accumulation of fibrin strands and a blood clot. In other words, atherosclerosis predisposes to thromboembolic disease, and indeed this is the main cause of death in people with diabetes. So why is it that people with diabetes are particularly prone to the development of atherosclerosis? Well, I think it's fairly common knowledge that, well, it's very common knowledge that insulin is going to lower blood sugar levels. But when insulin levels are low, that will allow lipids stored in adipocytes, mostly in the form of triglycerides, to come out into the blood, where they can be used as energy. And if you think about it, this does make sense, because if insulin levels are low, that means that blood sugar levels are low as well. The person probably hasn't eaten for some time, and yet it's still necessary to maintain the metabolic activity of the body. The body still needs substrates, it still needs fuels. So when the insulin levels are low, fat is able to migrate from adipocytes into the blood. And this is good in a starvation situation, because it means that we can still metabolize and produce energy by using up stored fat. But in a diabetic situation, it's not good, because if the levels of insulin are low, then fats will chronically leak out into the blood, and there will be a hyperlipidemia. And of course that will lead to a hypercholesterolemia as well. The cholesterol will rise. The low density lipoprotein cholesterol will rise, and this will contribute greatly towards the development of atherosclerosis. So it's particularly important in patients with diabetes that we're very careful to address the other risk factors that we know can lead to the development of atherosclerosis. So it's absolutely vital that patients with diabetes do not smoke. We know smoking is a significant risk factor for the formation of atherosclerosis, and someone who's diabetic and smokes, there's a synergistic effect. It's even worse for them, because smoking is going to lower the protective high-density lipoproteins and have numerous other nasty effects. So important that people with diabetes don't smoke. And it's also very important that we assess their levels of cholesterol, which we want to keep low. Now, guidelines in different places, different countries vary, but basically someone with diabetes wants to have a lower cholesterol than someone who does not have diabetes. So statins would be considered at a much earlier stage than in a non-diabetic patient. We want low cholesterol, because we're kind of stuck with a diabetes, but let's get the cholesterol right down so we can reduce the development of atheroma. Same with blood pressure. We need to be ruthless with blood pressure management in patients with diabetes. And again, ideally they want to be running an even lower blood pressure than we would consider acceptable in someone who is not diabetic. Exercise is very important. Exercise is good for the arteries generally. Exercise raises protective high-density lipoproteins, dilates the blood vessels, keeps the heart and lungs in good shape, and is generally a very good idea for everyone, but especially for patients with diabetes. And of course the whole dietary thing is important as well. We want a healthy diet. We want plenty of fruit and vegetables. Fruit and vegetables are good because as long as we take the whole fruit and vegetables, the sugars in the fruits and vegetables are associated with complex carbohydrates and fibers, and they diffuse out into the gut slowly. So fruit and vegetable has a low glycemic index. If you squeeze the fruit to get the juice out, then that's got a high glycemic index, so best to eat the whole fruit. So a generally healthy diet is good for diabetics. And on our previous talk we talked about the proportions of carbohydrates. Basically we want relatively high proportions of carbohydrates and lower proportions of fats. But the fats we do have, we want to have protective fish oils and omega-3s and healthy fats rather than the polysaturated fats. So really, it's generally promote a healthy lifestyle is the message. And a healthy lifestyle for someone with diabetes is similar to a healthy lifestyle for, well, the same really, as someone who has not got diabetes. So that's macrovascular disease. But bear in mind that the main cause of death in patients with diabetes is a coronary arterial disease. Be ruthless on the etiological factors for atherosclerosis. Next, I think we'll talk about microvascular disease. Now, microvascular disease, as the name suggests, is disease of the small blood vessels, the arterioles, the venules, and probably mostly the capillaries, the very small blood vessels. And what happens in microvascular disease is that the basement membranes thicken. Now, if you think about a capillary, there's going to be a basement membrane, and lining the inside of the lumen of the vessel are going to be the squamous endothelial cells of the vascular endothelium. And the basement membrane is a supportive tissue surrounding this layer of cells. And it's supposed to be very thin, but in diabetes, especially if the diabetes is poorly controlled, that membrane becomes progressively thicker, thickening of the basement membranes. And this has effect on several different systems in the body. Let's first of all think about the effect of microvascular disease on the retina. Well, when the basement membranes thicken, that is going to reduce the amount of blood that gets through, because the thickened basement membrane is going to impede into the lumen and narrow the lumen of the blood vessels. That means less blood is getting through to the retina. Now, the retina, for its mass, is massively metabolically active. It needs a very high oxygen supply. And if the oxygen supply is reduced, what the retina does is it starts growing new blood vessels. And the hypoxia caused by the microvascular disease in diabetes means that these patients are prone to what is called a proliferative retinopathy. Many new blood vessels start growing into the retina. The problem is that these blood vessels are often of very low quality and prone to hemorrhage. So they will hemorrhage, leaking blood out onto the rods and cones, onto the light-sensitive cells of the retina. And the retinal hemorrhage will progressively kill off the light-sensitive cells, resulting in progressive visual loss and ultimately blindness. So we need good glycemic control, and we need regular eye checkups. And what ophthalmic doctors can do is they can photocoagulate the new blood vessels and burn them off before they cauterize them to seal them before they have time to burst. And thinking about the kidney now, the basement membranes can thicken in the glomerulus of the kidney. And first of all, although the basement membranes are thicker, they are more pervious to protein. Normally the basement membrane will prevent formation of protein. It will prevent protein going from the blood into the glomerular filtrate. But a thickened basement membrane will not. It will allow albumin to get through. Very small amounts, but it will allow albumin to get through from the blood into the glomerular filtrate. Now, the amounts of albumin are small. You can't detect them on your ward-based dipsticks for protein. You need to send them off to biochemists into the lab, and they will diagnose the presence of microalbuminuria, small amounts of albumin in the urine. And this is important because it means that the diabetic nephropathy, the disease of the kidney, is kind of started. So we have to be very careful to improve control and to prevent the disease process from progressing. So both of those complications, really, the retinopathy and the nephropathy, based on basement membrane thickening. And as far as I know, it might occur in some other obscure diseases, but I don't personally know of any other disease processes where microvascular disease like this does develop. I think there are one or two rare things, but they are very rare. What should we think about next? Let's think about. I can mention cataracts when we do eyes as well. Patients with diabetics are more prone to cataracts, the opacity of the lens, although I'm not quite sure why that happens, but it does. They are more prone to cataracts. Let's think about legs and feet now. Patients with diabetes are very prone to problems with their legs and feet. And there are three reasons for this. The first is ischemia. Macrovascular ischemia will reduce the blood supply to the feet, causing distal ischemia. And this ultimately can result in necrosis and the need for amputation. So a complication of the macrovascular disease leading to ischemia. And of course that can be complicated, exacerbated by the microvascular disease, which also will contribute towards the ischemia. So they have trouble with ischemia. They also have trouble with immunosuppression. And this is another general principle in diabetes. If the blood sugar levels are high, then that's going to mean there's plenty of sugar in the blood and tissue fluids. And that means any bacteria which get into the blood or the tissue fluids are going to have a table already laid for them. They're going to have a food supply just waiting for them to use it as substrate. So the sugary environment in hyperglycemia means that the body is a slightly more friendly place for bacteria than it otherwise would be. Plenty of food are readily available. That means the bacteria can grow and multiply. And remember, bacteria can double their numbers because the generational time is less than half an hour. They can double their number some bacteria, they say, can double the number every 20 minutes, but certainly in half an hour you can have reproduction of bacteria in this sugary environment. And as well as that, because the environment is sugary, it inhibits the movement of the body's normal white cells. Normally, if there's bacteria in a tissue, this is detected there's a chemical detection of the presence of the bacteria by the body's own white cells, macrophages, for example, neutrophils, for example. The phagocytic cells, they would normally be attracted to the bacteria and they would phagocytose them. But they can't move effectively through sugary environments. So the more sugary the tissue fluids, the white cells can't move towards the bacteria effectively. It's called chemotaxis. The process of chemotaxis is inhibited. The chemo part comes from the chemical recognition of the bacteria, and the taxis part is the movement of these cells. So that's inhibited, they can't move. So that means the body's defences don't get to the bacteria, so the bacteria carry on dividing quite happily. Another factor actually in immunosuppression in diabetes is that the normal inflammatory response is very often inhibited. And indeed, this is a very important clinical fact that you need to know about. In someone with diabetes, you might not get the normal inflammatory response, the heat, pain, redness, swelling, loss of function, that we associate with the inflammatory response. And the reason for this is that the redness and the swelling and the heat in inflammation are all caused by very small blood vessels dilating. Inflammation causes a vasodilation, particularly at the level of the arterioles, venules and capillaries. But if you think about it, in diabetes, if the basement membrane is thickened, then that kind of closes off the small blood vessels. So when the inflammatory mediators tell the small blood vessels to dilate, they can't dilate because the thickened basement membrane is sheathing them in, it's holding them in, and you can't get the normal small vessel vasodilation. So that means a diabetic patient can have an infected wound, but you won't see the normal clinical features of inflammation. That means you have to have a particularly high index of suspicion that infection may be developing. And the other reason patients with diabetic patients have problems with their feet is the neuropathy, disorder of death of the peripheral nerves, neuropathic disease. This probably occurs, it's tempting to think that it occurs because of the microvascular disease reducing the blood supply to the nerves, and that may be partly true. But pathologically, it's certainly true that the Schwann cells, the protective myelin sheath forming cells, die off around the peripheral nerves. And of course, the myelin sheaths protect, insulate, and nourish the nerve fibers. And so loss of the myelin sheath leads to loss of the nerve fiber. There is death of the nerve fiber. And this takes two forms, although it can be mixed, but the most common form is the sensory type. It's the sensory nerves that are affected most. There can be motor involvement as well, but typically what we see is sensory neuropathy in diabetes. And this is important because it means that patients lose the sensation from their feet. They can't feel their feet effectively. And what this means is that there can be pressure points between the patient's feet and their shoes. And they can't feel the pressure like you would feel it. You would feel the pressure, well, even without noticing it, and then you would shuffle your feet around and the pressure would go away. But in patients with diabetes and sensory neuropathy, there is lack of sensation to the feet. And that results in pressure, and that leads to callus formation, hard skin, patches of hard skin. And if you look at patients with diabetic feet, there often are hard callus patches over different parts of the foot, normally where it's in pressure from the shoes. Now, what this hard callus does is it presses on the underlying tissues, and essentially it causes a pressure sore, because if you've got this hard callus pressing on the soft underlying tissues, it will close the capillaries off in those tissues, close the blood supply off, and you'll get a small area of necrosis. It's like a little pressure sore. And as we've already seen in diabetes, these patients are very, very prone to infection. So it's very likely that infection will develop under the callus. Now, in a non-diabetic, that will cause a lot of pain. Infection, of course, is associated with pain, and you would seek help with that. But in diabetes, they often don't feel the pain because of the sensory neuropathy. And that means that the infection can get quite bad, and the infections can often track into the bones, leading to osteomyelitis. And of course, once bones are infected, once there's an osteomyelitis, that is remarkably difficult to treat, virtually impossible to treat. And this is why often diabetics need toes cut off or various amputation type procedures because of the infection. So what you need to do is keep a very close eye on patients' feet with diabetes and get our friends the chiropodists to see them regularly. And what the chiropodist will do is sharp debridement. They will cut away the callus, open up the area underneath, and that will let any infection out. Sharp debridement. If there's no chiropodist available to you, then if you think you can do more good than harm, then I suppose that's what we have to do. But ideally, this is a job for specialists. It's the same with nails in diabetics. Again, the toenails should be cut by chiropodists. But again, if no chiropodists are available, then if we need to cut these patients' nails, then we do them straight across, making sure that we don't damage any of the soft tissues. Because all round about the edges of a nail and along the base of the nail bed and up the other edge of the nail, there's actually a seal between the nail and the skin, a bacteria-proof seal. And if that seal is intact, it's unlikely that infection is going to get in. But injudicious cutting of toenails, if you cut them like down into the corners especially, then infection becomes quite likely, and we can do a lot of harm. And of course, our aim is never to do harm. Neuropathy can also affect the bladder, leading to urinary difficulties. And unfortunately, the neuropathy can also lead to impotence, because if the nerves supplying the blood vessels to the penis are affected, then the blood vessels that dilate and constrict in order for an erection to develop won't work properly. Because normally for an erection to develop, there is dilation of the arteries supplying the penis, letting more blood into the penis, and there is constriction of the veins draining the penis. And that means that more blood is going into the penis than is being drained, and the cavernous spaces fill up with blood, and that's what causes the increase in size, resulting in an erection. But if the nerves supplying the arteries and the veins are affected by peripheral neuropathy, then unfortunately impotence can be a relatively early complication of diabetes. What else? We've talked about reduced inflammation. We've talked about infections. Probably worth saying a little more on infections. In diabetes, they are more prone to infection generally for the reason we've outlined. And wounds can become infected, and we might not notice. As people caring for diabetic patients, we might not notice because we miss the inflammatory response. So in someone with diabetes, if they have got wounds, keep a very close eye on them. Look at the exudate, look at the colour, look at the smell, and of course, if you're in any doubt, then culture the wound. Look for the bacteria. That will indicate the presence of infection, which we can then treat aggressively with antibiotic therapy. Patients with diabetes are more prone to heart failure as well. What seems to happen here is the sugar can migrate into the muscles. It's a glycosylation effect as sugar migrates into the tissues and reduces the pumping efficiency of the myocardium. But as well as that, of course, as we've already identified, patients with diabetes are much more prone to macrovascular coronary arterial atherosclerosis, which of course can lead to heart failure, left ventricular failure. So, most research has shown that the long-term complications are reduced with good glycemic control and by keeping some insulin on board all the time. Because remember, if the insulin is on board, that's going to prevent the breakdown of the fats. Insulin will actually also prevent the breakdown of proteins and keep body tissues in better condition. So someone with diabetes, we don't want the blood sugar levels to go too high. There again, we certainly don't want them to go too low. The saying is 4 is the floor. We don't want blood sugars to go below 4 millimoles per litre of blood. There again, we don't want them to be high for long periods of time either. So the latest research seems to be indicating that we should aim for a long-term sugar, an HbA1c, of probably, it does depend on the research that you read actually, but we should probably be aiming for around about 7, because that's going to prevent the hypoglycemic attacks, which are themselves associated with complications. In older people, for example, some new research is showing that repeated hypoglycemic attacks predisposes to dementia, which does make sense, because if the brain cells are repeatedly deprived of their glucose supply, it's not surprising that brain cells could be affected by that. So you've got to go by your local protocols, really, but if there's a ballpark figure, we say that we should be aiming for long-term HbA1c sugar results of around about 7. That would probably be acceptable to most people. Keep some insulin on board, prevent the hyperglycemias. Hopefully that will reduce the long-term complications of diabetes, and combine that with all the generally healthy lifestyle measures that we've talked about. And that means that the majority of patients with diabetes can look forward to decades of healthy life, because you are managing them well.